Hello, everybody. Here we will be talking about colistin, an antibiotic of yesteryears, which is finding a lot of interest now because of its activity against many multi drug resistant gram negative organisms. It acts by disrupting the outer membrane and the lipopolysaccharide of gram negative organisms. It is positively charged and interacts with the negative charges on the LPS. It introduces hydrophobic side chains into the LPS, causes displacement of calcium and magnesium divalent ions, causing disruption of the cell wall of the GNBs, ultimately leading to lysis and then cell death. Because of its unique mechanism of action at the outer membrane and the LPS, it is active against only gram negative organisms, but some GNBs are inherently resistant. Among these, the ones which find mention are Proteus, Providentia, Serratia, and Burkholderia. But the top three MDRs against which colistin has fair level of activity is Klebsiella, Pseudomonas, and Acinetobacter. The three which are very notorious for nosocomial infections, of being multi-drug resistant, including elaboration of carbapenomases. And here, colistin is one of the drugs which is of great use. Colistin is available in two formulations, as CMS, which is colistin methyl sulfate, and the other is polymyxin B. CMS is a prodrug and has to be converted into the colistin in the body, but this conversion is unreliable. Almost two-thirds or more of the drug will get excreted by the kidney without getting converted into colistin, and this is more pronounced in patients with normal renal function. So we are not very sure about the concentrations reached in the plasma when we are using CMS. Whereas polymyxin is an active ingredient, it does not require any conversion, because of which it has more predictable pharmacokinetics. We require a loading dose with CMS, whereas this is not required with polymyxin B. Colistin, the active moiety, does not have renal excretion. So when we are using polymyxin B, it does not attain good concentrations in the urine. Whereas CMS, which has renal excretion, gets converted to the active moiety colistin inside the kidney. So when it comes to renal infections, CMS is preferred over polymyxin B. Otherwise, because of its more predictable pharmacokinetics, polymyxin B would be preferred. Also, for use in nebulization, we use only CMS. Where do we have the use for these drugs? It's mainly for MDR gram negative organisms, and usually in combination, mainly because of the clinical circumstances in which they are used. Very critically ill patients, patients in whom you have to use empirically without any culture, or cultures which show resistance to many drugs. In that case, it makes more sense to use it in combination. This might also make sense from the point of synergy, which it is supposed to have with many antibiotics. It may allow antibiotic entry by disruption of the outer membrane and the lipopolysaccharide ring. It may have complementary action with many antibiotics. It is believed that it might decrease the MICs of certain drugs, including those of carbapenems, when used in combination. So majority of the time, its use in the ICU is in combination, usually with another beta-lactam antibiotic like BL-BLI combination or a carbapenem. It may also be used in combination with tigecycline, especially when we are dealing with MBLs. So it is something which is used mainly in combination, and we can also use both the IV and the nebulization formulation at the same time. What are the major concerns with colistin? The major one is nephrotoxic, and because of which it actually went out of favor. And the other one which should not be missed is neurotoxic. Neurotoxicity may be easily missed in the intensive care unit. Nephrotoxicity is very easy to pick, rising creatinine levels. With neurotoxicity, it may be more tricky. You may have a patient with severe neuromuscular weakness, encephalopathy, convulsions, or a myasthenia like weakness. All of these may be caused by colistin, and this should always be kept in mind whenever we are using it in critically ill patients. What about resistance to colistin? Yes, there is, and majority of the time it is due to altered binding sites. There could be flux pumps which throws the antibiotic out, inactivating enzymes, so-called colistinate, which are elaborated by certain GNBs. And there is also a issue of heteroresistance, which is basically in the colony of the organisms, some of them are resistant and some of them are sensitive. But with time, the resistant ones proliferate, and so it could be considered some kind of adaptive resistance, that in the presence of the antibiotic, the resistant colonies grow, and this can lead to secondary resistance when we are using colistin. This is also one reason where we want to use colistin generally in a combination therapy. What about the dosing? For CMS, we need a loading dose, and usually that is 9 MIU, and we use 4.5 MIU IVBD as maintenance. It's a concentration dependent drug, so we are using it in the BD dosing. With polymyxin B, the dose is 15 to 25,000 per kg body weight, and this would translate in a 60 kg men to 5 lakhs IV BD or TDS. In the presence of renal failure, CMS needs dose modification, whereas polymyxin B, it can be used without any dose modification. So regarding the use of colistin, always use it in combination therapy. Majority of the circumstances also compelling that it is used in combination therapy. And if it is not a renal infection in mind, we might consider using polymyxin B as the preferred colistin because of its pharmacokinetic benefits. In terms of spectrum of cover, both CMS and polymyxin B are supposed to give similar coverage against the drug resistant bugs.